You know, in emergency medicine, there's this saying that you hear all the time. Time is tissue. It's so true. Whether it's your heart or your brain, every single second that blood flow gets blocked, damage is being done. Damage you can't undo. So today we're going to jump right into the thick of it, breaking down the life or death decisions doctors have to make in two of the most critical emergencies out there, a heart attack and a stroke. Let's get into it.
Seriously, just imagine it for a second. The alarms are going off, the team is looking at you, and you have to make the right call right now. We're going to walk through these scenarios just like a top-tier medical team would, looking at the evidence and figuring out the absolute best move to make when every moment counts.
All right, first up, the classic heart attack. We've all seen it in movies, but what really happens? What's the right call when that clock starts ticking?
So picture this. Your patient is a 45-year-old man. He's wheeled in, and he is in some serious distress. And his age, that's the first thing that should grab you. This isn't just something that happens to older folks.
And the symptoms? Wow, they're painting a crystal clear and very scary picture. You've got that textbook chest pain, the kind that shoots down his left arm. But it's more than that. He's diaphoretic, that's the medical term for just being drenched in sweat, and he feels nauseous. These are huge red flags that the body's under incredible stress. We're way past indigestion here.
And then you get it, the smoking gun. The ECG, which is basically the team's eyes on the heart's electrical system, shows something called ST elevation. And that tells you one thing with no ambiguity at all. A major artery in the heart is 100% blocked. Blood has stopped flowing. This is a STEMI, an ST elevation myocardial infarction. And that clock, it's not just ticking anymore, it's screaming.
Okay, so you know it's a STEMI. What's the play? Do you blast the clot with powerful drugs? Do you rush him to a special lab for a procedure? Do you just try to manage the pain and see what happens? Or do you run even more tests? You've got to decide, and fast.
The answer, the only right answer here is B, immediate PCI. We're past managing symptoms. The mission now is to physically get that artery open before the heart muscle starts to die. So what exactly is this procedure?
Well, you can think of PCI as high-tech plumbing for the heart. A cardiologist snakes a super thin catheter all the way to the blocked artery, inflates a tiny balloon to smash the plaque blocking the way, and then, usually, they'll place a small mesh tube, a stent, to prop the artery open for good. It's direct, it's incredibly effective, and it is the absolute gold standard.
And this right here shows you exactly why PCI is king. When you put it head-to-head with thrombolytics, those clot-busting drugs, it just works better. It's more successful at opening the artery, and it has a lower risk of causing a dangerous bleed somewhere else in the body. But here's the kicker: speed. The goal is to get the patient from the hospital door to that artery being open in less than 90 minutes. It's a race against time where every single minute means more heart muscle is lost forever.
Okay, let's switch gears. We're moving from the heart up to the brain. The same principle, time is tissue, is in play, but the game has a completely different set of rules. So our next patient comes in. She's a 68-year-old woman. And when you look at her chart, one thing jumps right out: a history of atrial fibrillation, or AFib. Now, AFib is an irregular heartbeat, and the danger is that it can let tiny little blood clots form inside the heart. And if one of those little clots breaks loose, it can make a beeline straight for the brain.
And the signs she's showing, they hit like a lightning bolt. A sudden weakness all down one side of her body. That's a huge sign of a stroke. Her blood pressure is jacked up, which is pretty typical in this situation. And the fact she doesn't have a fever helps us feel confident this isn't some weird infection causing all this.
Just like with the ECG before, this is the make or break diagnostic test, a CT scan of the brain. But here's the fascinating twist. The most important finding is what's not there. The scan is negative for hemorrhage. There's no blood. This tells us it's not a bleeding stroke. No, this is an ischemic stroke. A clot is blocking a pipe, starving part of the brain. And that distinction, well, it changes everything because the treatments are complete opposites.
So, you know there's a clot in the brain. The clock is ticking. Again. What do you reach for? Do you use a powerful clot buster? Do you start blood thinners? Do you call a surgeon? The choice you make in the next few minutes will determine this patient's future.
And the correct move is B. You fight a clot with a clot buster. And for an ischemic stroke, the go-to weapon is a drug called intravenous alteplase, or TPA. TPA is an incredibly powerful drug. It's designed to find blood clots and just dissolve them, breaking them up so blood can start flowing again to the brain. You give it through an IV, and you hope it gets there in time to save those starving brain cells. But, and this is a huge but, there's a catch.
And that catch is the clock. There is a brutally short window to give TPA safely. We're talking just 4.5 hours from the absolute first moment the symptoms appeared. If you miss that window, the risk of the drug causing a bleed in the brain becomes too high. This is exactly why you hear those public service announcements. Act fast, because every second you wait could be the second that window slams shut.
So what about all those other options? Well, it all comes down to timing. They're not bad treatments, they're just the wrong treatments for right now. You don't start aspirin for at least a day. Heparin is actually dangerous in this immediate phase. And surgery or long-term meds like warfarin, that's all for way down the road. The only thing that matters in this moment is the TPA.
So, let's just zoom out. We've walked through a heart attack and a stroke, two very different organs with two very different treatments. But underneath it all, there is one powerful, unifying principle that ties them both together.
And this table just lays it all out, side by side. For the heart, you could say time is muscle. For the brain, time is brain. Look, the specifics are different. ECG versus CT, 90 minutes versus 4.5 hours, a physical procedure versus a powerful drug. But the core mission, it's identical. Get the blood flowing again as fast as humanly possible. Because with every tick of the clock, priceless, irreplaceable tissue is dying.
Which brings us to one last pretty exciting thought. We've spent decades getting these protocols as fast and efficient as they are. But what happens next? What happens when AI can read a CT scan faster than a human ever could? Or when advanced diagnostics can be run right there in the ambulance? How much more can we shrink these life-saving time windows? The future is coming fast, and the race to save every last second of precious tissue is definitely on.